Hello, I'm Kathy Neal, Managing Director with Mazars Healthcare Consulting, and I'm joined today with my colleague, Jennifer St. Marie, a manager within Mazars Healthcare Consulting. In this episode of Healthcare Digest, we will be discussing Medicaid transformation, what it is, why it's important, and hear about some early outcomes on some recent efforts. Did you know that Medicaid has been transforming since President Lyndon B. Johnson signed Medicaid into law in 1965 to provide healthcare access and financial protection to some of the sickest and most vulnerable Americans, including poor families and the disabled?
For those of you who may not know, Medicaid is a public health insurance program funded jointly by federal and state government, and the federal government has general rules that all state Medicaid programs must follow. But each state runs its own program. This means eligibility requirements and benefits can vary from state to state. Originally, Medicaid only required coverage of 5 benefits: inpatient hospitalization, but not including hospitals for mental illness or tuberculosis, outpatient hospital care, laboratory and x-ray services, skilled nursing home services for those over 21 years of age, and physician services. Initially, optional benefits included drug benefits, dental benefits, physical therapy, glasses, hearing aids, and prosthetics. Over the last 58 years, the required services under Medicaid expanded to 15, and the list of optional benefits that individual states may choose to administer has grown to include care management, home and community-based services, health homes, and hospice, among others. So you can see that Medicaid has been changing since 1965 to meet the needs of the population. Today, capitated managed care is the dominant way in which states deliver services to Medicaid beneficiaries, with 72% of those beneficiaries enrolled in a managed care plan nationally. States design and administer their own Medicaid programs within federal rules. States determine how they will deliver and pay for care. Nearly all states have some form of managed care in place: comprehensive risk-based managed care and/or primary care management programs. But what does transforming Medicaid actually mean? Medicaid transformation involves project demonstrations with federal government that allow testing at the state level of new and innovative approaches to providing care. Fundamentally, the purpose of Medicaid transformation is to deliver Medicaid benefits in a coordinated manner, so there's better integration of services, improved coordination of care, and more effective efforts to address social determinants of health that may be contributing to poor health outcomes and increased health costs. Why is it important to transform Medicaid now? The national health expenditure in 2021 was $4.3 trillion, accounting for 18.3% of the gross domestic product in the US. At the same time, Medicaid spending grew 9.2% to $734 billion, or 17% of the total national health expenditure. At this rate, Medicaid spending for 2023 is projected to be $834 billion and will be over $1 trillion by 2027. Simply put, Medicaid represents 1 out of every $6 spent on healthcare in the US and is the major source of financing for states to provide health coverage for low-income residents. Medicaid transformation is the same as Medicaid expansion, is it? No. Medicaid expansion became effective under the Affordable Care Act of 2010, when states were given the option to expand coverage of Medicaid to low-income adults at or below 138% of the federal poverty level. Medicaid transformation addresses how Medicaid services are delivered to beneficiaries. It's a drive towards whole person care and wraparound services designed to impact physical and social determinants of health to improve health outcomes. The social determinants of health are conditions in which people are born, grow, live, work, and age. It's their jobs, their neighborhood, their education, literacy, access to food, playgrounds, schools, healthcare, linguistically and culturally appropriate and respectful care. All of these things that drive health and well-being. Research has shown that 60% of an individual's health status can be impacted by social determinants of health. So if we want to be efficient and drive better health outcomes, we must find ways to address these social determinants. Wraparound services are not new, but they haven't been easy to access, nor have they been directly connected to medical care. Medicaid is fragmented. Different providers and payers are responsible for different services. Walk through the wrong proverbial door, and you might not get help at all. Think about it this way. You need to get ingredients for a meal, but instead of simply going to your neighborhood supermarket, you must go to different stores to get meat, fruit, vegetables, bread, and dairy. And at each of those stores, you must pay with a different credit card and navigate different rules about what you can buy and when you can buy it. Sound difficult?
Medicaid wraparound services include a range of services and care coordination designed to provide comprehensive, personalized supports and resources so that individuals and families are able to address the individualized, complex physical and mental health issues and challenges that are interfering with their health and well-being. Historically, non-medical services have been included as part of Medicaid home and community-based services programs for people who need help with self-care or household activities as a result of a disability or chronic illness. States can use a range of state plan and waiver authorities to add certain non-clinical services to the Medicaid benefit package, including case management, housing supports, employment supports, and peer support services. State plan authority waivers, such as 1905A waivers, include things like peer supports, case management, and health home options. Alternative payment models and federal matching funds for social determinants of health services and supports are examples of Section 1115 waiver programs. Home and community-based support waiver programs under the 1915 I and C waivers include community supports or in lieu of services and state-directed payments, as well as integrated care models of care. California has been transforming Medicaid since the early 1970s when they became the first state to pilot Medi-Cal managed care, California's version of Medicaid. Today, there are approximately 16 million Medi-Cal beneficiaries in California, with nearly 88% of them assigned to managed care plans. Adult Medi-Cal enrollees generally have several complex health conditions involving physical, behavioral health, and social needs, and over half of the Medi-Cal spending is attributed to just 5% of the beneficiaries with the highest cost needs. Additionally, the delivery of care is fragmented between several systems with different payers. Beneficiaries with complex needs must frequently participate in several delivery systems to access care, including primary and specialty care, dental care, mental health, substance use disorder care, and long-term services and supports. Recognizing this perfect storm of inefficiency and uncoordinated care, the California Department of Healthcare Services developed a framework for a broader delivery system to include programmatic and payment reform across the Medi-Cal program in October 2019. They called the framework California Advancing and Innovating Medi-Cal, or simply CalAIM. CalAIM has three primary goals: identify and manage member risk and need through whole person care approaches and addressing social determinants of health, move Medi-Cal to a more consistent and seamless system by reducing complexity and increasing flexibility, and improve quality outcomes and drive delivery system transformation through value-based initiatives, modernization of the system, and payment reform. CalAIM was officially launched in January of 2022, and several initiatives have since been implemented while others are being incrementally phased in over the coming years. The first initiatives were based in population health and care management strategies. Two we're going to look at were called enhanced care management and community supports. The first year implementation of these initiatives provided beneficiaries with better access to more coordinated, person-centered, and equitable care. But it's just the beginning of transformation journey under CalAIM. The early outcomes focused on access to the new benefits and lessons learned. One of the new wraparound supports for complex Medi-Cal beneficiaries is enhanced care management, or ECM. ECM services are comprehensive care management services that provide a whole person approach to care that addresses the clinical and non-clinical circumstances of high-need members enrolled in Medi-Cal managed care. The overall goal is to provide comprehensive care and achieve better health outcomes for the highest need beneficiaries by improving care coordination, integrating services, facilitating community resources, addressing social determinants of health, improving health outcomes, and decreasing inappropriate utilization and duplication of services. The concept of enhanced care management was modeled after the whole person care pilots of 2017, which demonstrated improvements in targeted utilization and outcomes, care coordination, then increased beneficiary engagement and delivery of housing services. These services are provided by community-based providers with the expertise and experience to address the unique needs of the beneficiaries, which differ across the populations of focus. The early populations of focus were in four main areas: high utilizers of avoidable emergency room and hospital visits, adults with mental illness or substance use disorders, adults experiencing homelessness, and adults transitioning from incarceration. As part of the requirements for ECM, the ECM care managers must meet the beneficiaries wherever they are at. In other words, on the street, in a shelter, in the doctor's office, or in their home. By the end of the first year, over 109,000 Medi-Cal managed care plan beneficiaries had received ECM services in 2022, the first year of implementation. The second initiative, community supports, or in lieu of services, are cost-effective alternatives to traditional medical services and settings designed to address specifically social drivers of health. Originally, the Department of Healthcare Services pre-approved 14 community supports for the managed care plans to choose from. Options included housing transition navigation, tenancy and sustaining services, recuperative care, caregiver respite programs, nursing facility transition and diversion to assisted living facilities, personal care and homemaker services, medically supportive food and meals, sobering centers, and home asthma remediation. By the end of the first year of implementation, over 36,000 Medi-Cal beneficiaries had received almost 81,000 community support services in the first year of implementation, the calendar year 2022. The top four community supports were housing tenancy and sustaining services, housing transition and navigation services, medically tailored meals, and recuperative care. With a focus on reducing healthcare costs and improving health outcomes, it's no surprise that 3 of the 4 most common supports or supportive of housing needs in this population. So, what were the early lessons learned in this journey? Enhanced care management must be more than care management. Documentation is critical and must be shared across the continuum for true care integration and coordination. Beneficiary engagement is not a given. There is often service duplication between care plans, community partners, providers, and PCPs that causes confusion and inefficiencies. There is significant overhead that requires a break-even point that small groups can't often meet, so there's provider overhead. Beneficiaries may not want in-person engagement, which requires some flexibility with contracting. Social referrals are managed by Community Supports Network, and if for some reason that community support doesn't have the capacity or there's a lack of timely feedback, there'll be delays in care. And finally, probably the biggest lesson here, paying for these services is difficult. There's a wide range of variability in the rates, sometimes as much as 300% variability. And community providers are very unfamiliar with how to bill for services. So they need a lot of support. But with all of that, there were also some real innovation and wins that were recognized with these processes. An example was with the Medically Tailored Meals Program. So the Medically Tailored Meals Program is a special diet that's delivered to the homes of recently discharged Medi-Cal beneficiaries to ensure dietary compliance of certain chronic illnesses. While Meals on Wheels, a common senior meals program, has a wait list, the Medically Tailored Meals Program does not. So by partnering with the Meals on Wheels program, some managed care plans were able to get their beneficiaries medically tailored meals delivered upon discharge from the hospital with the added benefit of a home visit by a volunteer who was able to identify needs and refer to community supports for other services if needed. This early intervention against loneliness affecting a senior's nutrition, emotional well-being, and mental health was parlayed through the Medically Tailored Meals Program to recently discharged high-risk Medi-Cal beneficiaries. So we see that Medicaid transformation is a journey that is happening across the nation. California is not alone in its innovation of care, but by sharing successes and lessons learned, we can truly impact the lives of this needy population. Thank you for joining and listening to this episode of Healthcare Digest. We hope you found our conversation on Medicaid transformation informative, and we'll be happy to further discuss this topic with you and your team. Please reach out to Jennifer or myself if we can be of further assistance.